Hello everyone, how are you? Here we are in this special Monday in Endocrinology VMR with Thiago. Thiago is amazing. He has contributed and is still contributing a lot to the amazing community of VMR. And I really I really feel I like endocrinology more because of Thiago. He has very educational ways to to lead to teach us endocrinology. So Thiago, can you please introduce yourself?
Thank you, Gabriel, for your kindness. So I am Thiago. I am an endocrinologist in Brazil, and I've been here attending CPSovers for a long time, almost 1 year now, because I learn a lot here. And today our goal is to discuss an endocrine unknown case and try to learn together some concepts and get there. So I think that today Rafael managed to have a case with Amanda. So I think she will present the case and then I'll pass it on to her so she can introduce herself.
Hi everyone, I am Amanda. I'm from Brazil too. I am a fourth year medical student and I'm so happy to be here today, and it's a big responsibility is here present a case to Thiago, but I'm so excited and I'm so happy to present this case.
So Anne-Marie, what should we do?
Okay, so if who's scribing tonight?
I am.
So Rafa, if you could get the screen up, we're going to do a little bit of a different
format. If you've been on Global VMR or some of the student VMRs recently, rather than having official discussants, we try to highlight everyone in the chat. So tonight, how it's going to work is that we want everyone to put your thought process in the chat. We might ask you to share that if you're free, and then at the end, Thiago is going to continue to share pearls and also share his thought process as well. So we want it to be as interactive as possible. So the more you contribute, the more everyone learns. Okay, so Amanda, we are ready to get this started.
So let's go. And this is a case by the Human Diagnostics that was created by Anand Patel, and it's a 28 years old woman with metastatic breast cancer who develops altered mental status overnight.
Okay, so Fernand says, my kind of patient. Fernand, do you have any thought process on the altered mental status?
Hi, everybody. Yeah, so we generally go through our famous MIST mnemonic where we think of metabolic problems. In a metastatic breast cancer patient, I really want to rule out hypercalcemia. Acute hypercalcemia can cause acute change in mental status. Really want to also know if there's a glycemia problem, hypo or hyper. Hypo or hypernatremia, these are the main problems I think about. If it developed overnight, it must be something acute. Vitamin deficiencies don't develop overnight. Other than this, we have to also rule out inflammatory problems, infectious problems, structural problems, mainly metastases that can sometimes bleed and cause an acute change in mental status. You can have parenchymal mets or leptomeningeal mets. But leptomeningeal is mainly subacute. And finally, we have toxins. Patients are subjected to a lot of medications. Some can cause mental status changes.
Awesome. Does anyone else have any thought process they'd like to share? I see some really good things in the chat. Sudhara, can I please let me know how to pronounce your name? Would you be willing to unmute and share your thoughts?
Yeah. So, one thing that we always run into is adrenal insufficiency in people who are on PD-1 or CTLA-based immunotherapy, which is becoming more common for cancer. And then another thing is metastasis to the brain involving the pituitary gland, causing panhypopituitarism and adrenal insufficiency.
Awesome. Jasdeep, any thoughts that you have?
I think Siddhartha mentioned what I was thinking about. So, sir, I don't remember all of them, but there are certain types of monoclonal antibodies or other chemotherapy agents that can lead to encephalitis or altered mental status. If, I would take a closer look at the chemotherapy medications and when were they started and all that kind of stuff.
Awesome thought process so far. Thiago, since this is endocrinology VMR, how would you approach this from like a subspecialist standpoint? What are some of the things that you would think of in this case?
So I think it's different to add some. It's difficult to add something here because we should use the missed mnemonic because of the altered mental status, and if we, as we know, it's an endocrine issue. So I liked Fernand Biche talking about calcium because if you have a breast cancer, you may have two reasons to have hypercalcemia, PTHRP. So PTHRP, PTH-related protein, is very common in breast cancer, and it can lead to hypercalcemia. And also the metastasis. So when you have bone lysis, then you have another reason to have hypercalcemia. So you have the metastasis and the PTHRP as possible causes for hypercalcemia. Also, if you have metastatic disease, it's not common for tumors to metastasize to adrenal, but it's possible. And often it's bilateral and leading to adrenal insufficiency. So it's a very interesting point because, yes, as I said, it's not common, but metastasis change the adrenal function, leading to adrenal insufficiency. And for sure, we have to look at her electrolytes. So I don't see a reason for her to have thyroid disease at this moment or diabetes. But yes, I will take a look in her electrolytes, especially, and also I would look for signs or symptoms of adrenal insufficiency. And as I'm very happy Fernand is here because when you are on chemotherapy or immunotherapy, then depending on what you're using, then you can have damage to different glands. So those are my initial thoughts.
Thiago, would you go over with, let's just say, we don't know, but that immunotherapy is present, kind of how some of like the hypophysitis versus adrenal insufficiency versus thyroiditis, some of the things that you would be looking out for?
Oh, sorry. So yeah, for adrenal insufficiency, you can have immunotherapy leading to adrenal insufficiency, and the problem is that it's not reversible. So I don't have patients in immunotherapy, so I would have to check a list to see which one affects each one of the glands. I don't see patients using immunotherapy, so that's something I would have to check a list. But yes, it's possible to affect thyroid function, and it's very possible to affect the adrenal. So, but I don't have a great knowledge about it, unfortunately.
Okay. And then Fernand, can you just go over what you were saying about immunotherapy being rare in breast cancer?
Yeah, most of the breast cancers, like 2/3, are hormone receptor positive. So they're fairly cold tumors, not responsive to immunotherapy. We have evidence that HER2 positive breast cancer and maybe triple negative are more immunogenic. We do not have approved immunotherapies for HER2 as of today. I know there were some vaccines in trial, but we have only one agent that's approved for triple negative, and it's a small subset of triple negative disease that has to be metastatic. So it's very, very unlikely to find a woman on immunotherapy in breast cancer, unlike lung cancer or bladder cancer nowadays. And we had another agent that was approved, but the follow-up trial was negative, so it was removed. The label was removed. So we only have one agent in a very small subset of triple negative breast cancer that's expressing a high amount of PD-L1. So I would not really link her presentation to immunotherapy until proven otherwise.
Okay, Amanda, would you share the case up to the labs?
Yes. So admitted with dyspnea 3 days, made NPO overnight due to concern in respiratory status, noticed to be lethargic and slow to respond to questions the following morning. On admission, the patient was maintaining appropriately. Metastatic breast cancer found in central nervous system, and is this.
Would you share the physical exam as well?
Okay, so in the physical exam, her vital signs is normal, lungs clear to auscultation, regular rate and rhythm with no murmurs, rubes, or gallops. Patient alerted and oriented 3 times, but answering questions more slowly, able to follow commands, and no focal neurologic deficits. 7 liters of urine output overnight.
Drew, what are you thinking about hypercalcemia in this case?
So we had discussed prior that that sort of the 3 most common things that we could think of when we were thinking altered mental status in cancer would be hypercalcemia, usually due to bony metastasis, or in the case of multiple myeloma, just basically essentially attacking the bones. CNS metastases that that are affecting a certain area of the brain, or maybe invading the pituitary and causing pituitary panhypopituitarism, and then immunotherapy. Fernand made the great point that for breast cancer, regardless of what type it is, immunotherapy is probably not in the picture. But now that we note that this patient has both bony and CNS metastases, I'm thinking that hypercalcemia definitely needs to be in the picture. We definitely want to get a calcium on this patient. And CNS metastases, I would think that we would probably also want to get adrenal labs and BMP to look for if there's anything related to like DI or anything like that, especially considering that this patient was putting out 7 liters of urine. What is this patient trying to diurese off?
Okay, Fernand, what are you thinking of here?
Again, I still think hypercalcemia is compatible with the acute presentation. And especially in electrolytes, we talk about the delta. So if you have a rapid change in your delta from a certain baseline, you can have acute changes in mental status. The polyuria is compatible with that because hypercalcemia causes some form of decrease in the gradient in the medulla of the kidneys, and you concentrate your urine less, and you're more resistant to ADH activity, so you develop polyuria. The other possibilities like that we always have to rule out are hyperglycemia, because DKA can present like this. She's young, she might develop diabetes, type 1 diabetes for some reason, and she can present with polyuria and altered mental status. We might have a dysnatremia with it. And obviously diabetes insipidus, either central or nephrogenic. Central would be related to some pituitary involvement by metastasis in the wrong place, or maybe thickening of the meninges around it. I would be surprised if this happened overnight. I mean, she must have been complaining of some symptoms before, but anything is possible with cancer. Nephrogenic diabetes insipidus is generally related to some drugs, sometimes infections affecting the kidney, involvement of the kidneys themselves by cancer, but it's generally lymphoma, not breast cancer. The drug that mainly causes damage to the kidneys and tubulopathies is cisplatin, carboplatin. With cumulative exposure to them, you can have a lot of electrolyte disturbances. So I'm still struggling to see how the kidney is the main problem here. So I would still look elsewhere.
Kush, do you have any thoughts?
Yeah, I was just kind of chiming in and, completely agree with what everyone else said. I think for me, kind of thinking clinically, I think the urine output is certainly what struck me the most. That's 7 liters, let's say, over 12 hours. So she's making, several hundred, if not more, cc's of urine an hour, which from my experience certainly can be seen with DI. And so that's kind of where I sort of shifted my thinking, knowing that we're going to get a kind of full swath of labs, I think, as everyone has, pointed out. So I think those are kind of the big things that I'm thinking in terms of how to frame and sort of shift my thinking, and then also in terms of diagnostics and management as well.
Awesome. Thiago, as an endocrinologist, when you hear someone say if you hear polyuria, or someone say that they feel like they're, having a lot of urine output, what are some of the things that you think of, and what is your differential in that case?
Yeah, so for polyuria, more than 3 liters of urine output per day, I can just think of 3 causes: polydipsia, mannitol use, or diabetes, being it type 1 diabetes, type 2 diabetes, or diabetes insipidus. So for this case, as we don't have a clue, she took mannitol for any reason, and her mental status is she's not responding. I would assume that she has diabetes, because, as I said, it's not possible for her to take water given her mental status, and there is no history of mannitol. Then for sure, we want to know her glucose and also her sodium and her osmolarity. Her urine is also useful in trying to understand what's going on. But I think about these 3 cases when I hear polyuria. And in this case specifically, she can develop type 1 diabetes, as Fernand said. And for diabetes insipidus, it can be both central or nephrogenic. For nephrogenic, hypercalcemia is a cause. And for central, it can be related to her breast cancer metastasized to her hypothalamus, not pituitary, because pituitary does not produce the ADH. So the ADH is produced by hypothalamus. Breast cancer or any cancer, it's not common at all to metastasize to pituitary, but for hypothalamus, it's a little bit more common, but it's not common. And thank you for sharing this schema. I don't know who is sharing, and it's the first time I see it, but what is here? So yeah, so if you take more water, mannitol, diabetes, or polydipsia, okay, oof, it's what it's not different than what I said, but I don't know who shared. So if someone wants to talk more about it.
I think that's Rafa who shared it.
Yeah, I did, but I nothing to comment on.
Yeah.
just to highlight the discussion, which is great.
Okay, and one important thing, sodium is not expected to be high in diabetes insipidus. Just to have this discussion. For her, it's different because she does not have access to water. But for most people with diabetes insipidus, if you have access to water, then you just will drink water and your sodium will be in the high, like 143, 145, the upper limit of normality. If you have access to water, you just drink you drink water, like water, and more water. I can remember a case I saw, I don't know, he was like 13 years old and he was drinking the water of his cat, because his parents were just saying to him that he was drinking too much, and then I have this thirst, and then he was taking his cat water, because the thirst is really important. But for her, it's possible to have hypernatremia, but don't expect hypernatremia when you are investigating a diabetes insipidus. That's what I have to add here.
Just thinking about, because another thing under differential was hypercalcemia. So in this case, what would you expect thinking about increase urine output with hypercalcemia? How would you differentiate that from diabetes insipidus from what you've seen?
Yeah, so hypercalcemia is one cause of diabetes insipidus, and it needs to be persistent. But once you have this polyuria, if you correct the hypercalcemia, then the polyuria will decrease, and also it responds to desmopressin. So that I'm in doubt because it's peripheric, but I think it's an exception. I'll just check it. If the hypercalcemia induced nephrogenic diabetes insipidus, how it responds to desmopressin, because I'm not sure. As a rule, it will respond to vasopressin, to desmopressin when it's central, because it's just do the same as ADH. So you give desmopressin, and if there is an answer, if things kind of back to the normal, then it's central. And if it's nephrogenic, it means that the kidneys are not responding to ADH, so they will not respond to desmopressin. I'm not sure about hypercalcemia. I know that if you correct hypercalcemia, it will get better, but I have to check the response to desmopressin, which I'm not sure.
And Fernand, you were sharing some of the mechanism of hypercalcemia and polyuria. Would you share some of that out loud?
Yeah, if I remember correctly from my from the old good days, hypercalcemia, around the loop of Henle in the medullary part of the kidneys, you have all this gradient produced by urea and all the osmotically active agents, and your gradient goes from 200 to 1200 across the loop of Henle. So if you have hypercalcemia, it somehow affects the production of this gradient. I can't remember specifically how. It must be some transporter, and the gradient becomes absent or at least decreased. So you would not be able to concentrate your urine beyond, for example, 400 milliosmol or something. So you you have less ability to respond to ADH. So the ADH can work in theory there, but it has a limit, which is the ceiling of the gradient. And you start peeing urine, and it's dilute urine basically. So it kind of paralyzes the kidneys until you fix the hypercalcemia. Same for chronic hypokalemia. In some specific way, it can also lead to nephrogenic diabetes insipidus by also affecting this gradient.
So I just took a quick read here, and according to up to date, the problem with hypercalcemia is that it causes autophagic degradation of aquaporin 2. So that's the reason it causes nephrogenic diabetes insipidus. So you decrease the number of aquaporin. And just a quick reminder, aquaporin is the channel which is AGH responsive. So AGH from hypothalamus will act in your kidneys, and then the water will be reabsorbed, free water. In this case of chronic hypercalcemia, you can have this nephrogenic diabetes insipidus because of autophagic destruction of the receptors. And it's partially responsive to desmopressin. So it's kind of in the middle.
Okay, awesome discussion, everyone. So Amanda, would you share the laboratory results now?
Yes. So BMP on admission is the sodium 136, potassium 4.2, chloride 102, bicarbonate 24, BUN 17, and creatinine 0.7. And we have the BMP after being NPO overnight. The sodium 144, potassium 4.1, chloride 105, bicarbonate 25, BUN 20, and creatinine 0.9. And the next aliquots, there is the exam that will give us the diagnosis. So I can say. So
does anyone, we can kind of talk about this data right here based on this further data, and we don't have a calcium level, so we're just going to pretend like the calcium is stone cold normal. Sorry, there's some limitations when you're using these cases, but based on this data, anything that's jumping to mind or any further evaluation that anyone would like to do to try to get to the diagnosis? Dr. Center, Uncle Bob, would you tell us what you'd be looking for on the urinalysis and tell us maybe how the specific gravity could help us in this instance?
Yeah, so if we're thinking about diabetes insipidus, and when I was thinking about diabetes insipidus, because this happened so acutely, I was wondering whether she could have had a vascular event to the pituitary gland. If she has diabetes insipidus, she'll have a very low specific gravity. Very low means significantly lower than 1.010, probably 1.004, 1.005, 1.003. And that would suggest that in the face of all of this urine, her urine is dilute. Now, we have indirect evidence of that because she was fluid restricted overnight and her sodium dropped went up from 136 to 144, which is a major difference. So I think this is pointing us towards the pituitary gland. And the fact that they're not giving us a calcium makes nephrogenic DI much less likely. And we're trying to figure out why something happened very quickly. And so I think a urinalysis, if we have it, would be very useful. Or if we had a urine osms. If we don't have that, then we're going to have to, it's one of those human diagnosis cases where they never give you what you want.
Can you go over your trick of looking at the specific gravity and converting it to a rough estimate of urine osms?
Yeah. Okay. First of all, you can't use this if they've gotten dye study. Dye study raises the urine specific gravity. But other than that, it's 1.0 something, and you multiply that something by 30, and that gives you approximately the urine osms. So 1.010 is urine osms of approximately 300, what we call isothenuric, where the urine osms and the serum osms are the same. And so use 1.010 as sort of your break point for that's neither concentrated nor dilute. Higher numbers are concentrated, lower numbers are dilute.
Awesome. Thank you so much. Thiago, if you were consulted on this case and had concern for diabetes insipidus, and we'll pretend like the glucose is normal, the calcium is normal, what would be your next steps in this case?
So for this case right now, it looks like diabetes insipidus because, polyuria and the sodium jump, I really believe it is diabetes insipidus, but I would love to see the urine, the osmolarity or the gravity. Osmolarity is better, but gravity can also help us a lot. And then I would give her the desmopressin and observe the urine output. So if it decreases, so after seeing the urine, I would give her desmopressin and see how it goes. Because if it's central, then we will see she will get better and better. And this is a case in which she needs treatment, because if we don't treat her, she will be dehydrated. She's not by now, and she also will be hypernatremic because she doesn't have access to water. For Sheehan syndrome, it's not common to cause a central diabetes insipidus because it's related to pituitary. And here, to have a central diabetes insipidus, you have to have problems in the hypothalamus. There are, however, case reports of Sheehan syndrome with central diabetes insipidus. So it's not common, but it's possible to have this kind of problem. But my next step here would be to take a look at her urine. If you cannot make a urinalysis, you can look to the urine, because if they know the urine output, probably you can see the aspect of the urine, and probably it's like water. That's what I imagine. And then I would make a test and try to see what's going on. For sure, we need to, another clue there would be where is the metastasis? Is it close to the hypothalamus or is it far away from the hypothalamus? So based on her history, we can, if we have access to the image, it helps a lot us. And also the calcium, as I said, because if it's nephrogenic diabetes insipidus, I would believe it's secondary to hypercalcemia. So having a calcium and previous images or head images would help us to better understand what's going on and treat her.
What are some of the things on your differential for central diabetes insipidus versus nephrogenic diabetes insipidus?
Yeah, so for central diabetes insipidus, you can have anything that is affecting hypothalamus. So whatever is there can be is a potential cause. So there are patients after trauma that they develop diabetes insipidus because of this trauma. Neurosurgery. So it's very common to see patients after neurosurgery having transient diabetes insipidus. Like when you take the thyroid, you see very often transient hypoparathyroidism, because parathyroids are very close to the thyroid. So it's the same for pituitary resection. So when you have pituitary adenomas and then you go to a resection, then it's very common to see people having transient diabetes insipidus. So surgery, neurosurgery, trauma, tumors, and any tumor, just being close to hypothalamus, it's a potentially cause. Infection, if you have a central nervous system infection, it can cause a central diabetes insipidus, no matter which infections. It's not common for most, like meningitis, but it's possible to have it. And, there are those rare causes like sarcoidosis and those kind of things. So this is what comes to my mind. I think that the most common is to have just a transient diabetes insipidus following transphenodal surgery for a pituitary adenoma. So actually it's very common, and that's a situation in which you can and you should make the diagnosis in the ICU soon after the surgery, just measuring the urine output, because then you can start the DAVP because desmopressin, because you know what's going on. You don't have to think about nephrogenic. So after a transphenodal surgery, just look at the urine output in the first 6 hours. And if it's like more than 1 liter in 6 hours, just give desmopressin, because it's probably a transient diabetes insipidus. As I said, it's transient because it's very uncommon to have a permanent lesion in hypothalamus following an adenoma resection. So this is what I think when I think about central diabetes insipidus.
What are some of the things that you're thinking about with nephrogenic diabetes insipidus?
So for nephrogenic diabetes insipidus, it's something I can't remember seeing because it's not so common to be with us endocrinologists. Often it is with the nephrologists, but there are some drugs that can cause diabetes insipidus, and one very common drug is lithium, right? So lithium users, they have nephrogenic diabetes insipidus. So it's very important to keep it in mind for lithium, and there are other drugs. Also, HIV is an important cause of nephrogenic diabetes insipidus, and hypercalcemia, as we were discussing. I'm not aware of other causes, but there are different causes, and the treatment is I can remember that they use hydrochlorothiazide, which is like, there is a reason, I don't remember why, it's something I have to reread, but nephrogenic diabetes insipidus can be treated with hydrochlorothiazide. I don't know if someone knows the reason and the rationale behind it.
Okay. Do you want to? Does anyone know the mechanism of that? I feel like I've heard it sometime, but I can't remember off the top of my head.
Hello, Thiago, was your question regarding how thiazides help in nephrogenic diabetes insipidus?
Yes. Oh, I know it's used, but I don't know the reason.
What I recall is from medical school that initially we have the water losing in case of nephrogenic diabetes insipidus. When you give thiazide, it also, first of all, decreases the volume status of the body. But after all, the whole volume status is so low that whatever a small amount of water is going inside the kidneys, it gets enough time to be filtered appropriately. So it was related to something like this, what I recall from my, yeah.
So it looks like, yeah, it induces a mild hypovolemia that can, I think, increase proximal sodium and water reabsorption, limiting water delivery to the ADH sensitive sites in the collecting tubules and reducing urine output.
Ultimately, basis is creating a state of less volume in the body, hypovolemia, as you said. Yes.
Great. So less free water will be available at the end of the nephrons.
Yeah, by the time you get to the ADH sites in the kidney, it sounds like. Okay, Amanda, do you want to share the rest of the case?
Yes, oh my God, so good discussion. And we have a serum osmos and 288, urine osmos 78, urine sodium 20, and a specific gravity 1006. With the final diagnosis,
what is everyone thinking about this data?
Please just, the specific gravity should be 1.006, just so that it looks right when people look at it. Thank you.
So
go on, Thiago.
Go ahead.
Go on, Thiago.
So the urine osmolarity is really low. 78 is really, really low. So when you have the situation and you have a urine osmolarity less than 300, you can guarantee it's diabetes insipidus or primary polydipsia. So here it's not primary polydipsia because she doesn't have access to water. But in this case of polyuria and urine osmolarity less than 300, it's too much water. So it's water. Water is just flooding. So it can be diabetes insipidus or primary polydipsia. And for this case, we don't have this doubt. We know it's diabetes insipidus. We don't know the reason. And I think that's the next challenge. And I think that Dr. Robert Center and Fernand have already said that they would make a test. And yes, you can give desmopressin, which is the drug to be used, and then you observe the diuresis. And in the next few hours, you can kind of have clues if it's nephrogenic or central. And as I said, you can use other data like calcium or head imaging.
So Thiago, what would you expect when you gave desmopressin? What would be diagnostic of central diabetes insipidus?
Yeah, so just one more comment, because I like to Hans in the chat. He's asking about IV fluids, but IV fluids, it's impossible to make this scenario, because when you have IV fluids, you have sodium with water. It's not free water. So for this reason, you wouldn't expect a urine osmolarity of 78. It would be much higher if it was. So it must be free water. So when you see polyuria plus urinary osmolarity less than 300, you have to think about water diuresis. And when I say water, I mean free water. So if you are taking free water, like in primary polydipsia, then it's possible. But if you are receiving IV fluids, it's not possible. And for this case, I would give her desmopressin, and then I would observe her urine output and her sodium. So in 6 hours, I would expect her to decrease her urine output and her sodium to decrease as well. Let's remember that when you have a problem in sodium, it's not a problem with sodium, it's a problem of water. So this jump in sodium, it means that she's becoming dehydrated. So you have more sodium because you have less water. So I would expect her to have her sodium increasing and her urine output decreasing if it is central. If it is a nephrogenic diabetes insipidus, then she will not respond to desmopressin. She will not respond to AGH because the problem is a resistance to the hormone and not the lack of hormone. So here we have to make this, that's the next step. Is it a problem? Is it a lack of AGH or is it resistance to AGH action? And I would observe her urine output and sodium.
Awesome. When would you do a water deprivation challenge? Obviously, we don't need to in this case because it was already MPO, but in what instances, if you were concerned about it, would you consider doing that?
Yeah, so the water deprivation test, you have to do it to observe what happens with the urine osmolarity. So if you have a low urine osmolarity in the setting of a polyuria, you don't need to make a water deprivation test. If it's not the case, then you will need to follow the osmolarity and see how it goes. So this is the moment that you make a water deprivation test. And it's mainly used to distinguish between, and you can make it to distinguish between primary polydipsia, because if you don't have a problem in hormones or hormone resistance, then your urine osmolarity will increase. So if it's primary polydipsia, if you suspect of primary polydipsia, then you just make this water deprivation test. And without water, the urine osmolarity will have a physiological response. And what is the physiological response if you don't have water? Your urine osmolarity will increase. But if you don't have AGH, or if you have resistance to AGH action, then you will see that the urine osmolarity will be low, even when you don't have water.
Okay, Amanda, awesome discussion, Thiago and team. Would you finish up the case and then we can go to teaching points?
Yes. So the final diagnosis is central diabetes insipidus, and given the patient's known history of CNS metastasis, the team was concerned about central diabetes insipidus. She was given DDAVP, and her urine osmolarity rose appropriately, and she was ultimately discharged on a regime of DDAVP, which helped to improve her polydipsia. Her sodium normalized with treatment, and her dyspnea resolved on its own, and underlying etiology was not discovered.
Okay, Thiago, any final reflections on this case?
Yeah, so great. You know, that's so when it happens, you're really happy because you know you are doing a good thing, because you know central diabetes insipidus, it's easier to treat. You just give desmopressin, DDAVP, and the answer is the response is very good. And for most patients who are not hospitalized, as it is her case, so for outpatients, the DDAVP is like asymptomatic, you know, because if you don't take a DDAVP, it's no problem, but then you won't sleep because you will wake every 2 hours to go to the bathroom because you don't have AGH. And if you don't have AGH, you will have a great urine output. So for outpatients, this is a great drug and they love it because it changes their life. Because as I said, diabetes insipidus is not life-threatening if you have access to water. You just take water and it's okay. But you know, it's a serious problem for quality of life because you have to drink water every time and you go to the bathroom every time. So it's a great drug, and people's life is much better when they take the JVP. It's widely distributed, so you can find it everywhere. And it's needed in this case in which she is hospitalized and with altered mental status. And probably I don't know if that's the case, but it looks like her diabetes insipidus is a consequence of her breast cancer metastasis. So she will have it after this acute decompensation. And so she will need to take this medication, and so she will have a great quality of life. And that's not a common presentation. I don't know what happened to her metastasis, because when you can think that it's kind of new, her diabetes insipidus, because her sodium was 136. It's really unexpected for someone with diabetes insipidus to have a sodium of 136. As I said, they are 143, 145. So I don't know why this metastasis is now causing it, but as it is, she will need the drug likely forever.
Okay, Gabrielle, would you take us away with teaching point?
Thank you so much for the amazing case and the unexpected final diagnosis. So for the teaching points, we were discussing about the background of breast cancer plus anterior mental status, and we were asking if this could be malignancy related or malignancy not related. So for a malignancy related etiologies that can present with altered mental status, we have hypercalcemia due to ectopic PTH secretion or bone metastases, hypoglycemia, adrenal insufficiency, and thrombosis or metastasis. And in case of malignancy not related, we have this amazing schema in the CP Solvers website of MIST, which stands for metabolic, infectious, structural, and toxins. And then in the history of present illness, we noticed that a patient had polyuria, which is defined with more than 3 liters per day. So in this context, hypercalcemia picture should be highly considered. And the mechanism is through nephrogenic, the mechanism is through the development of nephrogenic diabetes insipidus due to the regulation of aquaporin-2 channels, inhibition of NKCC channels and ROK channels, and the calcium deposition in the medulla. So there is an impaired generation of the interstitial osmotic gradient. And Thiago also commented on us that hypernatremia is not a common presentation of diabetes insipidus because the patient could have access to water and dilute the hypernatremia. In the labs were noticeable for a sodium jump, which highly suggested diabetes insipidus as a cause of the condition of the patient. So diabetes insipidus in a water deprivation context with this sodium jump, we were highly thinking of diabetes insipidus. So the next step was to differentiate if this diabetes insipidus has a central cause or a nephrogenic cause. So for the central causes, we have trauma, surgery, things that involve an increase in intracranial pressure, such as subarachnoid hemorrhage, or other etiologies such as pregnancy, familiar, or a hypothalamus compromise. And for the nephrogenic causes, we have electro abnormalities, such as hypercalcemia, hypokalemia, some medications such as loop diuretics, lithium, sickle cell disease, and some infections like HIV. Thank you so much for plugging in, and see you tomorrow on Neuro VMR.